Growing weary of running from room to room, practicing one-tooth insurance-driven dentistry? Then stay tuned for the latest episode of The Lionhearted, where Dr. Stephen Rasner will hand you the blueprint for what many call the gold standard of general practice dentistry.
Welcome to The Lionhearted. This has been going on for a few months now. This podcast is a continuation of the last podcast that was entitled What to Say When. So that's going to be a portion of this podcast. And then there's also some general, really solid practice principles that I like to go over with you that just have come to my mind this evening. So at the end of the last podcast, again, my email is drrasner@AOL. I love it when you write to me and tell me that we're connecting. I love it when you write to me and say that you give me ideas for other podcasts or what you would like to hear. So we're looking forward to continuing this movement, but back to the subject at hand, what to say when. And in the last podcast, I was talking specifically about introducing the concept of how to say you're going to do a comprehensive exam without doing a comprehensive exam. And I pretty much covered that in the last situation. And I want to take that right now when you have to say other things. Like clearly, your patients are not the same people. And it would be a mistake for you to, if you want to get to what we all call yes, is that not important to everybody listening? Right? Getting patients to say yes. Well, a lot goes in to that happening. It can't just be because you're an amazing clinician in Portugal, which downloads a lot of my podcast. So I'm becoming a big fan, by the way. Or New Zealand or Australia. So it's got to be other things. So let me sidetrack for just a second. You know, earlier in my early presentations about 10 years ago, I would talk about the 4 personality types. And they are directly related to case presentation and when to say what. So let me give you like a minute or two of this. You know, there's 4 personalities that everybody has. We have one of the 4. So one is a driver. So the driver personality you have to be on time for. All of this that I'm sharing with you goes into the concept of, yes, I'd like to do that. So they're, in case you're wondering, they're carrying their planner with them. They're looking at their watch. They're well-dressed, well-groomed. They got places to go. They're either going to come in and I'll get back to that. I'll say it right now. So these patients, surprisingly, sometimes want to come in. I had one in today. That they're so busy in life, they want you to get as much done as you can. Guess what helps with that? Oral sedation. It is really difficult, in my opinion, to have a patient keep it together for 4 hours or 5 hours in a chair and not be sedated. So I had a patient today for every bit of 4 or 5 hours that was sedated, orally sedated, with the cocktail and the protocol I've talked about many times at this point. I'm not going to go into it tonight. And it was quite effective. And we got lots and lots of work done. So they're like that, or they want a series of appointments. And they want you to be very structured. They'll probably want their first appointment of the day, and you better not be late. This may be a patient that's kind of formal with you. You might not make a mistake by calling them Mr. Such and Such, or I always take that road. If I'm not sure, I'll let them say, call me Steve, as opposed to just diving into that. Look, you think this isn't important? You think, hey, by the way, I think it's all important. I think washing your face, going into a mirror someplace in your office, brushing your teeth, rinsing your mouth, so that when you are in that room, you not looking kept is not one of the reasons you don't get case acceptance. And you better believe there are people who care about every facet of it. We'll go into another time about what you should wear. You know what? I'll tell you right now what I think. Okay, but this is how my podcasts go. I intend to talk about something straight and stay on that, and I can't. I am positive about what I'm about to say to you. I don't think it matters what you wear if you are so confident and so good at communication skills. There's probably a lot of things I'm not good at, but talking to a new patient would not be one of them. I'm very good at that. And I think I can help you be good at that. So I have worn in my 39 years, I'm not kidding about this, I've worn a tie every day. I had an associate recently that he wore a tie every day, and he looked really sharp. And I think if that what works for you, I just need to be comfortable. I have worn, there was one stage where I was fixing up my office for over a year, construction. I wore work boots and jeans and our typical dental gown on top of that. And you would hear saws in the background through the drapes that were hung between the room I was in and where they were doing construction. I wore operating, I can't think, surgical gowns, you know. I guess it's getting late in the evening, you can tell. But I'm not fit. I'm going to continue on this. I don't think it matters if you have great communication skills. Now, if I didn't, and you don't, err on the side of looking very professional, go with the tie, make sure that everything else is immaculate. Because you could look like you're out of GQ or out of Cosmopolitan magazine, and if you have bad breath and unkempt hair and a piece of Improgum on your skin and a cherry tomato in your loops because you came right from the lunchroom, you're dead. So don't do that. Okay. Back to the personalities. I told you about drivers. So with a driver, I will tell you with a driver, I'd be very tempted to say, well, let me tell you exactly what I'm going to recommend and why. So I would not deviate. I would not go off my normal, this is my 5-point exam. And I've really not had anybody ever stop me from doing that, no matter what type of the 4 personalities they had. The next ones are, by the way, drivers usually have good credit. Then you have socializers. Okay, this is the opposite extreme. Socializers are pretty easy to spot. First of all, they're fun. They're a blast. You love them in the office. They're in the waiting reception room talking to everyone. They're out your front desk, and they definitely want you to call them by their first name. They're delightful. I'm not kidding. They never get mad at anything. Oh my God, I love them. And I'm sure you know what I'm talking about. They'll stop by the office when they don't have appointments. They'll bring you things. So they exchange books and music with your team members, and you have no idea what's going on. They're wonderful. Now, they'll pretty much accept any approach you take to them if they trust you. The problem with socializers is they can be late. They kind of always have a story going on. Sorry, I'm going to say this. Their credit often stinks if they need credit. They often don't have enough money to do what they need to do. Other than that, they're all good. Okay, so with a socializer, your skill set on what you're telling them to, what you're recommending isn't quite as needing to be at an A level. If they like you, and they'll like you if you're social to them, then you're in Schaefer City. The next one would be thinkers. Now, thinkers, as you might imagine, could be the accountant types. They could be a professor. They're thinkers. So here's what you don't do with a thinker. You don't give them the treatment plan. You can give them a treatment plan if it's very easy on day one. But if they even hesitate for a New York second, let them go home and think about it. The worst thing you can do to a thinker is you got to give them statistics. That's not the worst thing. You want to give them statistics. You want to be very specific. Again, I would be a little cautious of how I approach them by name. If you're not sure, I would be formal. So, Dr. Such and Such. Let them tell you to call them Jeff or Steve or whatever. But I would not push them. Even if you flat out 100% know the treatment plan day one, I would not push them into a treatment plan. If they, for any reason, want to think about it, which they're going to want to, let them think about it. And whenever they're ready to come back, that's how I would proceed. And then the last one are relators. So relators are what you think they are. They're nurses. By the way, this comes out of a book. Most of us kind of know this stuff. A lot of us do. If you write to me, I can't think of the name of the book right. Non-Manipulative Selling. Sorry about that. Non-Manipulative Selling by, I can't think of the last name, Alexander somebody. But write to me, and I'll make sure you get it. It's not the Bible of this. I don't even know if you really need all that. Look it up on Google, because they might have other names for driver-related thinkers, socializers, but you'll get the point. So relators are nurses. They're nice. Sometimes they want to think about it. They definitely want to know how other people made out with the procedures we're talking about. They're going to want to have lots of questions. So you have to take time, more time than you would with a driver, to explain. Lots of before and after pictures. A lot of data, perhaps, that they can take home with them. Out of the 4 personalities, drivers, believe it or not, if it makes sense to a driver, even though they're a little bit intimidating, some of them may say, why do I have to pay now? I'm talking about the first visit. If you are strong and stand up to them, you're fine. If your attitude is, this is exactly what I would do, and this is why I would do it. And yes, we do get paid up front for a myriad of reasons that have worked for us over the years. Don't say it's your policy. Remember my last podcast? You don't use the word policy in my office. It's a negative, bad word. It's a turnoff. So if a relator needs time, then they get time. To be quite honest with you, I've made it clear in these podcasts and in comprehensive case planning that I do like to get paid. I like to give the treatment plan day one if I know it. There's a multitude of times I can't do that. And there's a multitude of times I can. But I want to be very clear about something because it's echoing in my mind as I'm talking to you. I don't care if they say yes at the first visit. I set it up in many ways for that to happen. How do I do that? By bringing a significant other 70% of the time. That happened today. Had a brand new patient in today. The reason this patient was in was because they were hurt by the last dentist. And wife was in the room. I had never met them before. It was a pretty significant treatment plan. I went through the whole 5-step process like you hear me talk about in prior podcast. And it went quite well. But that's one of the reasons I set myself up. If it's somebody who indicates that money, they've indicated that somehow over the initial phone call with Michelle, and they've indicated significant need. Very often, as I have tomorrow scheduled, this patient will come with a person that may be able to help them, or they'll leave us a phone number, of which I will get on the telephone, which I've done hundreds of times in my career. I didn't say thousands, because I'm really trying to keep you informed on exactly what does happen and not exaggerate things. And I am prepared. We'll have a little conversation about that at a later podcast to discuss how do I handle that when I jump on the phone. And basically, I just say, listen, I know your time's valuable, and I know you couldn't be here today. And I do this quite often, so I'm pretty good at communicating to you the clinical significance of the things in Johnny's mouth. And I understand you may or may not be helping him, so you can understand why I'm going to recommend, or what Michelle will be telling you when I'm through speaking with you. So, yeah, I want to get to yes. And yes, I spend an hour of that. But if I don't know the treatment plan, I mean, for goodness sakes, if it's, implant related and there's not abundant bone, and if there's sinus lifts involved and all the things that often drive my treatment plans, then I need additional data. But listen, maybe you disagree with the following statement. I've done this quite a bit, quite a long time. And my observations are that the great majority of patients do not enjoy or want 2 or 3 consultations, even if they need it, regarding their work. I also truly believe that unless you have a hotsy-totsy practice, perhaps in Manhattan or Beverly Hills or somewhere else, where patients are very used to going to this doctor for dentist for this and that dentist for the next service, a lot of patients, particularly in rural areas of America and the rest of the world, appreciate a competent doctor who's mastered more than one arena of dentistry. Because if you think about it, I understand why. It's a very personal thing that we do. And now we're asking them, you're giving them a choice where, and again, I have to underscore a competent dentist. You get to know me well enough, you will know I'm not an advocate of a weekend course on implants without significant training or any of the services that we provide. You only get to be masterful by a lifetime commitment to CE. It's that simple. So when I can present, listen, first bicuspid comes into my office. Sounds like a joke, right? First bicuspid broke into the gingival margin, poor crown root ratio, history of root canal, even with the gingival margin. Yeah, in the 1990s, in the 1980s, I would have done a cast post gold core that I learned at the University of Pennsylvania. In the 1990s, I would have done orthodontic extrusion, which we do still do on occasion to attain a adequate ferrule. But I have to be honest, it's pretty easy for me to treatment plan in 2019 an implant for a tooth under the situation I just described. Okay? So yeah, I don't need to bring that patient back for that. That patient's getting that treatment plan as long as I've gone through the 5 areas of my examination. So back to specific variations of talks you might give during that initial new patient doctor encounter. Excuse me one second. Don't edit that, Beth. I'm a real person, drinks water. And they need to know that. So let's say you're with the patient that you're telling this to. You heard that this patient, they're in their mid-50s. You look at them and tell me you can't relate to this. They don't have any crowns. I have 8 on my molars, okay? All my molars are crowned. And my dad was a dentist. They have 1 or maybe 2 missing teeth. They have some level, not advanced, of periodontal disease. They don't have particularly attractive restorations, the ones that they have. I mean, there's no hint of secondary or tertiary anatomy, marginal ridges, or any other things that were pounded into our head in first-year dental school. So come on. That doesn't say to you, well, you better really think about how you're approaching this patient who's never had a hint of comprehensive care. So I would begin, just like I told you I've begin my examinations with all my patients. I would tell them exactly what to do when. Like I'll tell them, one of the best things I've learned in my career was the concept called what to do when. And those of you that don't know that concept, just go back to previous podcasts and the 5 podcasts that were labeled comprehensive examination 1, 2, 3, 4, and 5. And you'll find it in there. And I would say to this patient, at some point in the examination, I would back up when I know we're getting into work. Now, I want to keep something in mind. I go into these examinations often, usually, to try to come up with the least invasive, the least costly treatment plan I can come up with, as long as that will work. And I won't hesitate to share that philosophy with the patient in our chair if I think it's an appropriate time to say it. I'll say, listen, if I'm looking at the patient I just described, I'll say, I have to say something to you. I'll say, what do you do? They'll say they're a policeman, they're a teacher, they're a factory worker. It doesn't matter what they say, a nurse. I'll say, well, I'm sure you would agree there's all kinds of levels of every occupation. And that's the case in dentistry. And I want to tell you something. There are all kinds of doctors. There's one doctor I'll call Good Old Joe. So that's the purpose of this talk I'm giving you right now. And I'll say, you know what? Good Old Joe is loved by everybody in his practice. For years, they love him. And one of the reasons they love him, he's very nice. Great personality. He probably belongs to many of the clubs they belong to. They also love him because they never need anything. And when I'm saying this and you're saying this, the patients start to laugh because they know. It could be the most conservative 20-year-old driving car person that you know. They don't spend a nickel. I can't tell you how many of those patients I've turned into healthier oral care patients. Many, many, many. And it begins with this conversation that you and I are having right this second, that I'm talking to this new friend of mine, this patient in my chair. And I'll say, good old Joe always told you look good, or we're going to watch this and watch that. And that went on for 30 years. And guess what? Sometimes you get away with that because a lot of problems in my profession are not symptomatic. So they don't hurt even when something's wrong. And then good old Joe finally retires. Or he sells, or worse. And now, just like you're kind of forced to go to somebody new. And I'm that new person right in front of you right now. And the reason I'm telling you this is there are, I know you came into me in here today because you had that filling that came out and there's a large sharp area and a large hole around your tooth. But I told you I look at you for five areas for a very good reason. Because if I do that, you'll save both time and money in the long run. If you trust me on that, if you believe I'm not in here, I'm not trying to get in your pocketbook. Now, I may say this, not every word I'm telling you every time, but this is how I approach a patient that's never had comprehensive care, is in today because something made them have to do something. Maybe it may not even be a toothache. Maybe just be a large MODBLGFD restoration. And I don't try to change every resto in their mouth at this particular treatment recommendation. But I make it clear that there's areas of their mouth that will fall under what I call, in my world anyway, the have-tos. Like, I have to ask you to I have to recommend scaling and root planing, even though you're not in pain, even though you have less than 15% bone loss. I have to really recommend that you address a number of teeth at this point. I mean, my job right now, and over the next couple years, and we don't have to do this all the first time we're together, is to get you to the patient, to the health state that my patients that have been coming to me and at this point say 10 years or 20 or 30. It's wonderful if you're still working over 25 years and you can say, my goal is to get you to the level of health of my patients that have been coming to me for 25 years. You know why? Because those patients are now in their 70s and 80s and some in their 90s, and they don't need much. If they came to me with teeth in 19, whatever it was, or 25 years ago, and those teeth were salvageable then they still have those teeth. If that's what you want, that's the doctor whose chair you're sitting in. That's how I talk. I don't know if this is coming across, especially if you can't see my eyes right now, but this is how I roll. I mean, this is what I do. And that resonates with even the most conservative patient. Now, maybe not everybody, not 100%. There's always going to be somebody that just thinks you're looking to get in their pocketbook. And no matter what you say or do, that's going to be the end result. And that's fine. That's fine. You are better off. Trust me. Because let me tell you something else. When we get to the part where I have to talk about money. So let me just stop for a minute. I try to segment a patient like I just discussed into the most conservative segments of treatment I can do. So maybe they have to have scale and root planing. Maybe they absolutely, at least under my eyes and my observation, maybe they have to have 2 or 3 full coverage crowns. So we're assuming in this patient that they don't even need a root canal, God forbid, because now I got to deal with that too. I'm making a few assumptions, but if there's other restorations, and I'll say that to them, I said there's 8 other fillings in your mouth right now that if we were at a dental school or I was given an examination, I could justify telling you to have a full coverage crown. And by the way, new trick, I just came out of the air for me in the last, I would say, 6 months. If it's a molar that you're crowning, which it usually is, turn to the x-ray that's right in front of them and say, this is one of the teeth that you have to have crowned. I said, you know how old you were when you got that tooth? You were 6. And the one next to it you got when you're 12. My molars are crowned and my father was a dentist. It is not an unusual service that a patient may need that seeks higher level of care. What do I mean by that? When I say that to you, I'm talking to the patient. It means that if I do it right, if I provide my service correctly, and I can keep you on a healthy maintenance schedule, then there's a very, very good chance we won't need a root canal. Or we won't be faced with, do we have to extract a tooth or save the tooth when you're 84 years old? Isn't that a better scenario for you? So again, my friends on podcast land, I guess I've gotten carried away with how far to go with each podcast. But by the way, I'm going to leave it with one final thing. And I know I have more to do on this. And maybe there'll be a what to say part 3. I'll write it down. I hope to make that the next podcast. But I want to say this to you. And this is important. Whatever you do treatment plan it for the worst case scenario. So if you're not sure it's an MOD, call it an MOD. Let's say you look at the upper right or left lateral incisor and you can't find a periapical area, but boy, on the x-ray, and they say it's asymptomatic, but it looks like it's right in the nerve, call it a root canal and explain that dental pathology is different than the rest of the body. It doesn't have to hurt. Just trust me on this for a minute. This is why you do that. Because if you follow my blueprint long enough, sooner or later, you're going to run into a situation where a procedure needed more than you told the patient. Now you have to remember something. You are walking the road less traveled. Most of your comrades do not do comprehensive exams, whether they're in Europe or the United States. And I'm here to tell you, if you turn around into their third visit, no matter how ethical you are, no matter how honest you are, and tell them you were wrong about this tooth, it needs a root canal, that's not going to go over well with most patients. I don't care what they say to you. I don't care if they pay you. You're setting yourself up to get a bad Google review. And if you want my remedy, if it's an anterior tooth, it takes me 25 minutes to do a beautiful restoration, a beautiful root canal result, I'm going to probably eat it. I mean, I'm not going to eat it if I just gave out a $2,000 treatment plan, or there's special circumstances why I was so conservative. But if you got somebody on board that dove in and trust you, and you better really think about the services you add, and do you have to do them right then and there? Like, for example, a filling that really turned out to need a crown, I would do a core buildup and tell them such. And tell them I'm not sure of the longevity. You're human. You try to be conservative, and maybe you were conservative to a fault. Anyway, I guess we're up to 32 minutes. I don't want you to get tired of this. Again, please let me know if this is helping you. I'm really trying to... it takes a lot to keep doing these, and I'm approaching like 15 or 16 of these at this point. I hope they're helping some of you, so let me know if that's the case. And I'll see you probably next time on The Lionhearted with part 3 of What to Say When. Have a great week in your office. Keep writing to me. Thanks a lot. See you then.